Indeed, an honor for me to be presenting a lecture in front of my own teacher. I feel blessed and indebted for that. Thank you. So, hearing balance and falls in midlife women. Prima facie, how many menopausal women coming to our OPD with the complaints of falls and dizziness, and we questioning them about their hearing symptoms or hearing properties? I guess not many of us. So, the motive of today's lecture is to recognize sensory deficit as the contributor of fall in middle-aged women, understanding their hearing and vestibular dysfunction, maybe nutritional and some medicine-related risk factors may be underlying, screening such women in menopausal clinics, timely referring them to the ENT specialists, and saving them from having any further debility related to falls. Now, why do we need to talk about falls, first of all, in this age group segment? Falls are a geriatric problem. No, it's a misconception. Falls start their etiology in the perimenopausal, menopausal age group long before the old age sets in. So many women might report to upper OPD with the complaints of dizziness, hearing difficulties, imbalance, and simply the fear of falling. They might not be falling altogether, but they might be experiencing near falls or just the fear of falling down. And why this needs to be addressed? Because just one fall, simple one fall or one fracture in this age group might lead to reduced motility, loss of confidence, hence social isolation, and later mental depressions. So the clinical scenario which we might be facing as menopause expert in our clinics, patient XYZ, maybe in the age group 40s to 50s, might be coming with the complaints of increasing difficulty in hearing, especially in the crowded areas, occasional dizziness. She might feel unsteady while walking, especially in the dim light, and 2 or more than 2 near falls in last 6 months. This needs to be addressed because almost 40% middle-aged women suffer from some or the other degree of hearing loss, and sensory deficit may be the main warning sign behind it. So what we need to do as menopause experts, not the ENT specialists, we are the gynecologists, and what we need to question them, is this the menopause or something else? So we need to discuss the symptoms here and differentiate the symptoms between the menopause and the ENT concerned symptoms. Then any underlying vitamin deficiencies or the medication side effects, maybe any kind of vestibular dysfunction or early sensory aging if it's going towards the ENT symptoms. Just a small input to how do we maintain balance? First of all, it's the 3 cardinal points: our eyes, inner ear for the balance, and muscles and joints as far as proprioception is concerned. So these 3, the visual system, vestibular system, and the somatosensory system, coordinate with each other. And finally, the brain coordinates the information from these 3 and gives the output in the form of balanced gait and equilibrium. Now we need to differentiate here. Thus, is it the simple menopausal symptoms like brain fog, sleep deprivation, fatigue or anxiety, palpitations, or the simple subjective dizziness? Or is it something else related to vestibular pathology, cardiovascular causes, or neurological disease? In the present lecture, we will be staying limited only to the vestibular pathology, and the vision part, proprioception, cardiovascular, and neurological will be left. Coming to the vestibular dysfunction, what happens is in the menopause, the estrogen declines, we all know that. Estrogen receptors are there in the cochlear vestibular apparatus as well as the central nervous system. So when the estrogen itself is declining in the body, the possible consequences are the reduced auditory processing, vestibular dysfunction, slower neural integration, leading to the postural instability, and finally resulting in near falls or falls. So the vestibular system, which is the body's internal GPS basically, which detects the head movement and maintains the gait, posture and gaze and coordinates the entire balancing, Once it goes here and there, the symptoms of dysfunction sets in, mainly in the form of vertigo. The common vestibular dysfunctions in midlife women may be BPPV, vestibular migraine, Meniere disease, and persistent postural perpetual dizziness, in which PPD is mainly overlapped by the anxiety symptoms, Meniere's disease with tinnitus, vestibular migraine mainly sets in with the hormonal fluctuations, and BPPV is triggered by the head movement. So, this is how, as a gynecologist, just by these small facts, if we know, we'll be able to differentiate these kind of diseases. Where we need to refer to the ENT specialist straight away, not to intervene here. These are the red flags. Sudden hearing loss, neurological deficits, severe headache, diplopia or ataxia, facial weakness, or stroke like factors. Just an insight into the graphic representation, how the vestibular system functions. The sensorineural input once goes down, the estrogen levels goes down, it is directly going to affect the semicircular canals and the cochlear part and the entire vestibular system as a whole, leading to imbalance and falls. Now, what is the etiology behind it? Some of the nutritional deficiencies, mainly vitamin D, B12, and iron. Here also, how can figure out? With iron, she might be presenting with fatigue along with dizziness. With B12 deficiencies, there might be gait instability and peripheral neuropathies. And with vitamin D, severe muscular weakness can be accompanied along with the near fall or fear of falling experiences. One of the main culprits, which most of the time we miss on interrogating, is the medicine induced dizziness. This is an age group where females are having multiple problems, small things they are having, but they keep on running from one physician to the another, from one therapist to the another. So, what happens basically is they are either on the antihypertensive, diabetic medications, they may be hypoglycemic, they may be on the sedatives or antidepressants. So, we need to interrogate if any kind of medicines are the culprit. As menopause practitioner, what we need to do? Just a simple questionnaire. Any falls in the past year? Near fall experiences? Dizziness? Difficulty hearing? Walking problems in the darkness? Fear of falling? Medicine changes or visual impairments? When did she last have her eye checkup done? Apart from that questionnaire, which is going to give us a clear insight on whether she is having any menopausal issues or the vestibular function dysfunctions, if we want to dig deep, we can go for these sets tests: timed up go test, Romberg test, and tandem gait. Because of time constraint, we'll not go deep into it. We should be referring to ENT specialist if she is having persistent hearing difficulty with tinnitus or the asymmetrical hearing loss or recurrent vertigo, positional dizziness, or chronic imbalance status. This is because if we early intervene these patients, the better rehabilitation strategies can be planned out. Along with that, if the menopause expert and ENT specialist design a case scenario where they are incorporating the services of audiologist, physiotherapist, and nutritionist, it can give her a better comprehensive approach and care to the patient where she has a better quality of life altogether. Some of the fall prevention strategies would be hearing assessment done, vision correction done, vitamin deficiencies and iron therapy given, strength training and balancing exercises are the mainstay. The yoga therapy, we need to motivate the patient to go for the strength training, yoga, and balanced exercises. And the take home messages are: falls begin long before the old age. Hearing loss can be a significant overlooked factor as a contributing factor. Vestibular disorders are common. Vitamin deficiencies and medications might be contributing. So, early screening as a menopause expert in the menopausal clinic is a role where we have to play a significant role and timely decide when to refer to the ENT specialist. So, our aim at the menopausal clinic should be what she is doing at the age of 10, we should make her help do that at the age of 80. Thank you.
This was really an excellent presentation, and I feel it is a very ignored topic in our usual conferences. And I agree with you that dizziness and giddiness is a symptom, everyone ignores. The patient ignores, the relations ignore, the doctors ignore, and just give us some vitamins. It was amazing, and I think we should really think more seriously about this.
Thank you. Thank you so much, ma'am. Thank you, sir.
With the history of fall. And what I could realize with my practice is patient they suffer with two problems. First is the anemia, and second is the vestibular problem. So for that we use apply technique, and most of the patient, 90% of the patient, they get relief with that. So thank you very much.
Thank you so much, sir, for the input.
Now I request all chairperson and speaker to come forward for the photo session.
Neglected one, and this should be added to our menopause clinic. We have never heard of it in our conferences, so it's a new topic and a very very apt topic.
So claps for the scientific
Yeah.
discovery. वही क्वेश्चन है सेशन जो है ना